Thank you, Anik. And hopefully I won't fall off the platform here. I was just trying to distract everybody because she was we're talking about my topic. So I'm going to be talking for the next 20 minutes on abdominal and pulmonary complications of immunotherapy. I have no relevant disclosures. I'd like to thank my colleague for some of the chest cases that I'm going to be showing you. As we've heard by Mizuki's wonderful lecture, that the mechanism of action, the toxicity profile, the onset of toxicity, and the management of toxicity is very different in immunotherapy when compared to chemotherapy. And how do you know you're dealing with one of these novel agents? Well, if there's an AB at the end of the drug, it's an antibody. IB, it's an inhibitor. So one works on the cell surface, one works within the cell. And if there's an MU in the name, mu, that means it's murine derived. So in keeping with their unique action, mechanism of action, the immune checkpoint inhibitors have shown conventional and unconventional response patterns, as we've heard, including pseudoprogression, and also I'm going to be talking about immune-related adverse effects. So this looks a lot like your slide. So you can have hypophysitis, thyroiditis, vitiligo. We don't see that on our imaging studies quite yet. Arthritis, adrenalitis, colitis, and pneumonia. So how common are immune-related adverse effects? Actually, some of them, like arthralgias, diarrhea, and colitis, are fairly frequent, and then there are less frequent ones like pneumonitis, and I'll be talking about those. So when is the time of onset after the initiation of therapy? Well, for diarrhea and colitis, it's usually at about 5 weeks. For liver toxicity, it's usually about 7 weeks. And for pulmonary complications, sometime between 8 and 14 weeks. And the thing that's interesting about immunotherapy compared to conventional cytotoxic chemotherapy, usually immunotherapy has a prolonged mechanism of action, but also the complications tend to be more prolonged as you compare to patients who are on conventional cytotoxic therapy. Also, you tend to see more immune-related adverse effects with CTLA inhibitors like ipilimumab, and not less frequently in patients with PD and PD-1 inhibitors. However, if you have combined therapy, nivolumab and ipilimumab, the incidence of significant complications increases. The management of these complications may include delaying the dose of therapy, using steroids or infliximab, and discontinuing therapy. So it's kind of counterintuitive. Here we're trying to increase the immune system of the patient, but it's so revved up and so active that you actually have to give steroids and infliximab to reduce the immune response. Happily, the use of steroids or infliximab does not appear to compromise anti-tumor activity. Targeted oncologic therapies, actually, there's a positive correlation between the development of immune-related adverse effects and response to treatment. There's a 36% response rate with patients with grade 3 and 4 colitis, as opposed to 5% of patients without colitis, and 55% response rate with radiographic evidence of an immune-related adverse effect, as opposed to 10% without. And it's very important for us to recognize the imaging and clinical findings of immune-related adverse effects in order to differentiate them from disease progression and infection. And let's talk about pulmonary complications, and Mizuki should actually be giving this lecture. This is a wonderful article, and all the brains are actually from, and all the topics are from Mizuki's wonderful article. And she discussed some of these: pneumonitis, sarcoid-like granulomatosis, pulmonary hemorrhage, PE, pleural effusion, and pneumothorax. Pneumonitis usually occurs 8 to 14 weeks following the onset of the therapy. And you can see all of these begin or end with an AB or an IB, except the mTOR inhibitors, which always have a MUS at the end of their name. Pneumonitis is an uncommon but potentially fatal toxicity. And when you have monotherapy, you have 5% incidence, but if you have patients who are getting combined immunotherapy, it kind of doubles. The most common symptom is dyspnea and cough. And the pneumonitis is graded from 1 to 5, 5 being death. Unfortunately, it's difficult to diagnose checkpoint inhibitor pneumonitis because there are no really specific clinical or radiographic markers. It can mimic tumor progression, and it may be difficult to differentiate, this pneumonitis from an infection, especially in patients who cannot undergo bronchoscopy. So you can have a pattern like cryptogenic organizing pneumonia, as we see in this patient, with discrete, patchy, or confluent consolidation with or without air bronchograms. Actually, I think the ones we see most often are ground glass opacities, and these are discrete focal areas with increased attenuation with preserved bronchovascular markings. And here's a patient who's on combined therapy, pembro and nivolumab, and you can see after 14 months of therapy, this patient has rather extensive ground glass opacities. You can see increased interstitial markings, interlobular septal thickening, peribronchovascular infiltration, subpleural reticulation, and honeycomb pattern in very severe cases. Hypersensitivity reaction. You can get central lobular nodules that are bronchiolitis-like, and in tree and bud micronodularity. And it's very hard to differentiate these sometimes from infection. And then a nonspecific pattern, that's my favorite. Okay, this is actually from Mizuki's article. Rituximab can give you a very severe pneumonitis, as you can see from one of her illustrations in her article. Bronchoscopy with lavage may assist in excluding infectious etiologies, but if infection cannot be ruled out and bronchoscopy is not practical, some algorithms advocate broad-spectrum antibiotics with steroids in these patients. Patients with grade 2 or greater pneumonitis, the patient's given steroids and monitored with pulse ox and pulmonary function tests. With grade 3 or greater, the patient's usually put in the ICU and given steroids, and the patient's usually withdrawn from the immune checkpoint inhibitors. Sarcoid-like granulomatosis with adenopathy, and it can be seen with both CTLA and the PD inhibitors. And the diagnosis you should suspect when there's a particular nodular pulmonary opacities and symmetric mediastinal or hilar adenopathy. And it occurs about 5 to 7% of patients with melanoma treated with ipilimumab. And here we can see patients with bilateral hilar adenopathy. And in a patient with cancer, when you see new adenopathy, you have to worry, are these metastases, or is this adenopathy associated with the immune checkpoint inhibitor? And here we can see this uptake in both HILA. And, the differential diagnosis is metastasis, infection, and tumor progression. Pulmonary hemorrhage, these aren't the immune checkpoint inhibitors, but again, this is novel therapy. Again, it ends with an AB or an IB. You can get pulmonary hemorrhage. Avastin-related bleeding is the most common adverse effect in patients who are getting Avastin as part of their treatment for non-small cell lung cancer. And actually, in the package insert for the patient is warned about bleeding, vomiting, and coughing up blood. Pulmonary embolism, even without immunotherapy or specific therapy, patients with stable cancer have an increased incidence of incidental pulmonary embolism, 2.5%. And pulmonary embolism is a major complication associated with VEGF inhibitors. 19% of patients who are getting treatment for colorectal cancer, and if you added Avastin, they have a pulmonary embolism. Also, sunitinib and sorafenib are associated with thrombosis and pulmonary embolism. Pleural effusion. I love the name of this drug, dasatinib. It sounds like desaturation. This can lead to injury to the pneumocytes and alveolar capillary endothelium, and it leads to leakage of fluid and can lead to pleural effusions. Pneumothorax. The anti-angiogenic therapy can cause rarely pneumothorax in patients who have metastases that are greater than 3 cm in size, and it can be seen with this agent, so this patient has a pneumothorax. Also, here we can see a patient with a bronchopleural fistula, and also patients can get cavitation. And the incidence of cavitation is increased fourfold when you're getting these agents. And again, the ending is either with an ib or an ab at the end. And I think it's very important that you have part of your requisition, what type of agent is the patient getting? Are they an immunotherapy or not? And if you see an ib or an ab at the end of it, think that this might be a novel cancer treatment agent and that it might be immunotherapy. And here you can see the cavitation. Also, in patients who've had radiation therapy, when you're given these agents, you can get recalled pneumonitis in the areas of the radiation portal. Here's dasatinib, and as I said, you can get pleural effusions, and some patients get very bad pulmonary artery hypertension, and also systemic hypertension, and actually it's a surrogate marker for the efficacy of anti-angiogenic therapy, and believe it or not, when you get hypertension, these patients actually have a better response of their tumor. And pseudoprogression, you were talking about that, and so when we have the melanoma clinic and I'm reading those cases, I feel like that sometimes. Mizuki also talked about pneumonitis and pseudoprogression, and sometimes it can be very difficult to differentiate the two. You know, I report it, and I say this, since it is rare, I say this may represent pseudoprogression in this patient on an immune checkpoint inhibitor. And here's another patient who had pneumonitis and pseudoprogression with melanoma and treated with ipilimumab. And you see it more commonly in patients with ipilimumab. Now, abdominal complications. Elevated liver function tests occur in about 1 to 10% of patients who are on monotherapy, but if you're giving 2 immune checkpoint inhibitors, it increases to 30%, and sometimes the toxicity can be quite severe. The patients have right upper quadrant pain, nausea and vomiting, anorexia, fever, jaundice, encephalopathy, and they can get hepatomegaly, periportal edema, periportal hyperintensity on T2 weighted images, and large periportal lymph nodes, gallbladder wall edema, and the differential would be viral and alcoholic hepatitis and immune hepatitis. And here's a 33-year-old man with stage 4 melanoma who developed hepatitis grade 3 after the 3rd dose of combined therapy. And here's a patient with stage 4 melanoma who developed hepatitis grade 3, and notice the periportal edema. The management depends upon the grade. You may just withhold it, or the patient may need steroids. Immune-related adverse effect colitis. It's actually the most common adverse effect from immunotherapy. It typically occurs 5 weeks after the onset of therapy, and about a third of patients with IPI get it, and about 7 to 9% get grade 3 and grade 4. And again, if you have combined therapy, it's even more frequent. You can get a diffuse colitis, a segmental colitis, and of course you have to differentiate it from an ischemic colitis and also pseudomembranous colitis and another infectious colitis. So in your differential, when you see somebody with colitis, you know, you mention that in your differential, but also say this might be immune-related adverse effect. You can get a segmental colitis with diverticulitis, or an isolated rectosigmoid colitis without diverticulitis. And there's a grading pattern for that. And it's interesting that these patients, you can give them steroids, and then actually you can give them infliximab, and that's what you give for inflammatory bowel disease. So while we're treating their patient's cancer, we're giving them symptoms similar to ulcerative colitis and Crohn's disease. So you treat it the same way, steroids and infliximab. The findings that you see are mesenteric vascular engorgement, bowel wall thickening, fluid-filled colonic distension, pericolonic fat stranding, and again, the differential is ulcerative colitis, Crohn's disease, and pseudomembranous colitis. And here's a patient with a 72-year-old man with stage 4 melanoma who developed grade 4 colitis after the 4th dose of IPI. Happily, at tumor board, we say IPI and Nivo rather than have to say the AB at the end, because it's a mouthful. Here's a 42-year-old man with stage 4 melanoma who developed diarrhea-related colitis after the 2nd dose of IPI. And here's a patient who developed recurrent squamous cell cancer, and the patient actually developed pneumatosis. And pneumatosis can be seen in patients who are on both immunotherapy and novel anti-tyrosine kinase agents such as Gleevec. You can get pneumatosis, and of course you have to worry about ischemic colitis. But if the patient's not terribly sick and they're just there for their follow-up scan, the pneumatosis may just merely relate to their therapy. Pancreatitis is rare. It's associated with increased serum amylase and lipase levels. And it looks a lot like patients who have autoimmune pancreatitis, because when you think of it, it is kind of an autoimmune pancreatitis, but their IgG4 levels are normal. So here's a patient who got it after their first dose of Pembro. And here's another patient. You can see that the pancreas is very active on the PET scan. Adrenalitis is uncommon, and of course, you know, when patients with lung cancer, for example, and you're treating them with immune checkpoint inhibitors, and you see bilateral adrenal enlargement, of course, your first thought it's going to be metastatic disease. But again, see what agent the patient is on, and it may merely represent an immune-related adverse effect. Acute cholecystitis can be seen in patients who are receiving hepatic artery infusion of chemotherapy, patients with hepatic artery embolization, and patients with tyrosine kinase inhibitors. And then also this happens unfortunately in patients with GIST who are treated with Gleevec. You can get a fistula and perforation, unfortunately, and actually that's a good sign that the chemotherapy is working, but again, you have this fistula. So in conclusion, the increasing use of molecular targeted therapy and checkpoint inhibitors has important implications for imaging, especially with regard to surveillance for drug toxicity and the assessment of tumor response. It's important to recognize the toxicity patterns associated with different targeted therapies, both for identifying drug-related complications and for differentiating drug effects from disease progression. And failure to recognize these complications may be mistaken for recurrent disease and disease progression leading to cessation of therapy in therapy that's actually effective. So again, this is the problem with pseudoprogression, that you must be sure that you're dealing with pseudoprogression, especially in a patient who's on immunotherapy. Happily, it's very uncommon. Our patients actually have a card with them to tell what agent they're having. So when they present to the emergency room with their card, so the emergency room doctor knows, this patient, you know, could have an infectious colitis or could have an infectious pneumonia, but perhaps it's immune-related adverse effect. And with that, I thank you for your attention.